hear me?
The broadcast is now starting. All attendees are in listen-only mode.
Hello, hello. Can everyone hear me?
Yes.
Thank you. Great. Thank you for joining today's Advances in Autism Research and Care webinar entitled AIRP Nutrition Updates. Before we get started, I want to review a few housekeeping items and let you know how you can participate in today's event. We're looking at an example of the GoToWebinar attendee interface, which is made up of two parts. The viewer window on the left, which allows you to see everything the presenter will share on their screen, and the control panel at the right. Within that control panel is how you can participate in today's event. So let's take a quick look. By clicking the orange arrow, you can open and close your control panel. The audio pane provides audio information. Please ensure you have chosen telephone audio and dial in. Once you choose the telephone, dial-in information will be displayed, including an audio pin. If you would like to ask any questions of today's presenters over the phone, you must enter your audio pin in order to have your line unmuted. At the end of the presentation, you have the ability to send questions to our webinar staff through the questions pane. Simply type in your question and click send. You can also indicate that you have a question and would like your line unmuted by raising your hand. We will address Q&A at the end of today's session, and as a final reminder, today's webinar is being recorded, and everyone will receive an email with a link to view a recording of today's event. And now, Dr. Corey will present our presenters. Hello?
We're waiting for Dan.
Dr. Corey? Did we lose Dr. Corey? Okay, we have momentarily lost Dr. Corey. We can just give him 1 second, please, everyone. Hello, Dr. Corey.
Hi, I'm back.
There we go.
Yeah, for some reason when you hit record, it has a tendency to kick me off. So.
Oh, that's not a good thing. Okay.
Okay, so sorry about that glitch, folks. I'm back. As I was saying, this is reporting some additional information from the AIRP Diet and Nutrition Study, which was one of our first signature studies. Some of the results from this study were published in the supplement to Pediatrics in 2012, and today we're going to hear more from a couple of the study investigators discussing omega-3 fatty acids and vitamin D. Dr. Susan Hyman and Dr. Pat Stewart are going to be presenting for us, and I'm going to turn things over at this point to Dr. Hyman.
Thanks, Dan. Can you all hear me?
Yeah. I hear you.
Okay. So what we'll be doing over the next 45 minutes or so is reviewing two of the objectives from the diet and nutrition study. And Jesse, can you advance the slide, please? What we'll be doing first is reviewing what the overall study was for those of you who haven't heard prior webinars. Today we'll concentrate on discussing the adequacy of omega-3 fatty acid intake from diet and supplements in children in this group. We'll look at where they got this nutrient and look at the relationship between reported behaviors relative to intake. And secondly, we'll look at vitamin D intake from food and supplements in these children, which is one of our core goals for this study. Next slide, Jesse. So this is an overview of the diet and nutrition study. For those of you who've heard this before, please bear with me. What we did is we recruited from 5 sites, from Cincinnati, Colorado, Arkansas, Pittsburgh, and Rochester, a total of almost 300 children with autism characterized through the AS ATN. And we had the families complete very in-depth 3-day dietary records. During this time, we obtained additional information about behavior, bowel habits, some blood parameters, and we had a number of hypotheses that we tested through this in-depth dietary analysis. One, what Dan alluded to, is we published what children ate in the pediatric supplement in 2012. We just submitted a manuscript looking at the supplements that they've used. Ann Reynolds, our collaborator from Colorado, published one study looking at iron, and she has another one in the hopper. Today we'll be talking about vitamin D, and we have recently analyzed the data related to stool production in this group, and I want to congratulate our collaborator from Pittsburgh, Cindy Johnson, who just had a study in JAB looking at the behavioral parameters related to feeding from this group. So Jesse, can you advance to the next slide? So sort of a thumbnail of what we have identified and reported on already from this population are that, number one, you all know, because you're autism experts, that children with autism are selective eaters. What we also found is that they, while being selective eaters, that they have the same dietary insufficiencies as other children in America who don't have autism, that they have decreased intake of potassium, fiber, vitamin D, vitamin K, calcium, and choline. And I might add, Jill James, our collaborator from Arkansas, reported on the choline intake and how that impacts metabolism. What we also found is that in the younger children especially, that they had excessive intake of sodium and zinc. The manuscript we just submitted reported on the supplements that these children were given, that over half of them were given nutritional supplements, and it went from 0 to 13 per day. The most commonly used supplement was a multivitamin mineral preparation, again, much like the children that were surveyed through NHANES, which is a national database of children, irrespective of health needs. And what we found, what precipitated this current analysis, was that almost 15% were given omega-3 fatty acid supplements. Next slide. Next slide, please. Oh, I'm sorry, could you go back one?
Okay. Sorry about that.
That's okay. We found that children with autism in this sample had no greater likelihood of poor iron intake than the general pediatric population, but that 8% of them had low serum ferritin, despite eating enough iron. And the data that Cindy just published documented that feeding problems were indeed present and captured on the Brief Autism Mealtime Behavior Inventory, and that these feeding problems were associated with other repetitive behaviors, sensory symptoms, and other behavioral symptoms. And, as you might expect, that children who had feeding behaviors reported also had poor nutrition compared to the other in the group. So, if you'll progress to the next slide, what we wanted to do was to evaluate one of the supplements that the children were given, common supplement across all of our sites, and look at not only intake, but how that correlated with other parameters that we had data on. So the first we'll be talking about today is omega-3 fatty acids. And if you could advance to the next slide. Most of you know that omega-3 fatty acids are actually essential. Your body doesn't manufacture them in appropriate physiologic quantities. They're very important in brain development, explaining why they're present in infant formulas and breast milk. They have important roles in regulating blood clotting, in inflammation. They've been demonstrated to have beneficial effects in heart disease and other disorders. Macular degeneration is one of the demonstrated potential treatments with a nutritional intervention. However, because they are important for so many body functions, they've been tested for a number of disorders. And you can see that there are a whole host of disorders that supplemental omega-3 fatty acids have been evaluated in, but have not panned out. Next slide. To just remind you where we get omega-3s from, you see in the bottom left-hand corner ALA, which is alpha-linoleic acid, and these are the plant-based omega-3s. That's flaxseed and canola oil and other oils. That is much less bioavailable than the serpentinoic acid and the docosahexaenoic acid that come from marine sources. So algae in the ocean are eaten by small marine mammals or eaten by fish, subsequently eaten by humans. And in the United States, we have this extra course to omega-3s that fish meal is used in artificial chicken feed, which is why you can buy omega-3 eggs in the supermarket. So we have these two sources, a fish-based source and a plant-based source, with the plant-based source being much less bioavailable. Next slide. So why are we interested in omega-3s in children with ASD? Well, because they have physiologic impact on stabilization of membranes in the CNS. They have a role in both production and metabolism of dopamine and serotonin, among other neurotransmitters. There's been great interest in the role of omega-3s in neuropsychiatric disorders. And going back to 2006, there was an randomized controlled trial published in a small number of children with autism looking at high-dose DHA plus EPA, the fish-based, algal-based omega-3 fatty acids, on behavior. And what they found in this group of children with autism is that there was a large effect size on the stereotype behavior and hyperactivity after 6 weeks of treatment, as measured on the aberrant behavior checklist, but no statistical significance compared to controls who were given placebo. Another study was done several years later, slightly larger sample size, children 3 to 8, who also had ADHD, because in parallel to this there was an intense interest in the use of omega-3 fatty acids for ADHD. This study used 1,300 milligrams per day of a combination of DHA plus EPA, again, the more bioactive forms compared to plant-based omega-3s. And they used the same outcome measure, the aberrant behavior checklist, saw no change compared to placebo over 12 weeks of treatment. And they questioned whether, when you measure actual blood levels, whether the fatty acid profile in the blood may predict which children might have behavioral change. What was very interesting is the same group very recently published a study based on IAN recruitment, the Interactive Autism Network. And what's interesting about this is actually their methodology, because what they did is they recruited people with families of children with autism through the IAN network. So these were people all over the country. Didn't ever bring them into one site, didn't confirm diagnosis, using standard, the way we would do it in another research study. They identified 57 children, ages 5 through 8. Again, gave them a large dose, 1,300 milligrams per day in 2 doses. And what they found is that on the ABC again, that they had a greater improvement in their hyperactivity subscale with the omega-3 supplement, although it wasn't statistically significant. There was a Cochrane review a few years ago that, again, based on these studies and a number of open trials and case series, did not have evidence sufficient to support supplementation. And similarly, a Cochrane review on the use of omega-3s in ADHD did not feel that there was enough data to recommend routine supplementation. However, more recent studies indicate that there may be an additive effect with methylphenidate, at least in some children. Next slide. So based on the question and our inclusion of 43 children who were given omega-3 supplements in the diet nutrition study, we wanted to look cross-sectionally at how much did these children eat, how much were they given as a supplement, and what did the behavioral parameters show. So what you see in this slide, on the bottom in green are the Institute of Medicine recommendations for daily omega-3 fatty acids by age, and in the pink, the World Health Organization recommendations. The green includes the plant-based ALA, of which only 10% is felt to be able to be physiologically used, and it makes some assumptions about the amount of EPA and DHA that children actually consume, so that for this analysis we used the World Health Organization guidelines, which actually is based on DHA and EPA, and since that is what most supplements contain, more accurately represents our population. So if you just look at the numbers for children 4 to 6, for example, years of age, the adequate intake is between 150 and 200 milligrams per day. And what you look at in our data from this group is that of the children who we had complete data on, including were able to verify what the manufacturer said was in their supplements, we had 243 children who did not take supplements, 43 who did, and of the children who were in this arm of the study, there were significantly more females who were given supplements, and the maternal education was significantly greater for children who were given supplements, but they were otherwise similar in terms of age, DSM-4 diagnosis, and IQ. And what you see is that from food alone, so those are the first two horizontal columns, that the intake is really pretty similar and pretty low. That if the range in children between 2 and 10 is between 100 and 250 milligrams per day, we're getting 1/10 of that, a little bit more. When you look at the addition of supplements, however, the mean intake for the children who are given supplements was 775 milligrams per day, median 431, and of these children, only 12 were given over 1,000 milligrams a day, which were doses that were comparable to the studies in the literature. Next slide, please. So this slide tells us about, just percentage-wise in a more dramatic way, of who was able to meet their adequate intake based on food alone. And you can see out of all of these children, there was only one child who was able to do that. From supplements, what's very interesting is that despite supplementation, a little less than a third of the children still did not reach their adequate intake, and 65% of the children who were supplemented exceeded the recommended intake. So we don't know whether that was intentional, whether families were trying to replicate the studies that were in the literature, or that the supplements that were used were packaged for adults and not young children, so that they inadvertently got too high a dose. But you see that only one child met their intake from food alone. Next slide. And the source of the omega-3 fatty acid in the one child who was not supplemented was eggs. That nobody ate fish. And I won't say nobody. There were a few kids at some of the sites who ate fish, and there were a few kids that ate salmon. But very much like what was seen in the NHANES, that most children in America just don't eat much fish. So, next slide. What we wanted to do is look at the behavioral measures that were collected for this study relative to omega-3s for this analysis. And what you see here is an analysis of the association between supplement use, yes or no, independent of dosage. And if you recall from the 3 randomized controlled trials, they all used the aberrant behavior checklist as an outcome measure, which we did not use. They all found that there was there was improvement in the hyperactivity subscale, but it didn't reach significance. We don't have a control group here. But what you can see is that when you compare the supplement use yes and no, that the externalizing subscale of the CBCL in which hyperactivity might be captured was different, as was the CHSQ total score. And I might add that for those of you who've read the Amminger original report, in the very first paragraph, they talk about how parents anecdotally report that sleep is altered with the use of omega-3 fatty acids, and then no subsequent reports look at sleep. So this might suggest that future studies might want to examine this more carefully. And something that we found quite notable is that the repetitive behavior score, repetitive behavior scale revised, was impacted by the use of omega-3 fatty acids, which might account for some of the stereotype behavior that was seen in the RCTs. Next slide. When we looked at the scores relative to the total amount of EPA plus DHA, which was calculated to reflect usual intake, what we found is that the repetitive behavior scale remained significant, as did the externalizing score on the CBCL, and the BAMBI to reflect eating behavior. And it's impossible to know whether children who are less picky eat more foods that like eggs or fish, or whether there's some other aspect of being able to supplement them, because omega-3 supplements, as you know, for those of you who are clinicians, can be unpalatable. So we thought that this was provocative data that will inform future trials. So if you can go to the next slide. There are limitations to this data. This is a cross-sectional representation of the child's experience. We have no way to know that the reported amount of omega-3 ingredients were exactly what was in the supplements that were provided, since there are no quality measures that are required for food products as opposed to drugs. And in terms of looking at the behavior outcome, that a very small number of families gave their child a large enough dose to be comparable to the RCTs. Next slide, please. So what we would like this group to go away with is that the dietary sources of biologically active omega-3 fatty acids consumed by children with autism include eggs, chicken, and fish. The supplements given by parents don't reach the recommended intake in a third of the children and exceed the recommended intake in over half. And that future studies looking at the behavioral impact of omega-3 fatty acids need to have a wider range of measures that include sleep and may have more robust measurement of repetitive behaviors, but that unlike some of the other nutrients that we've examined in this study, that children eat so little omega-3 fatty acids that the supplementation is really all that needs to be measured in future studies. And now I would like to hand this over to my collaborator, Pat Stewart, who is going to talk to you about the next part of this.
Thank you, Susan. So Susan did a nice job of reviewing the intake of omega-3 fatty acids and the correlation to behavioral outcomes in children in our study. Now I'd like to turn to vitamin D, which is another nutrient we looked at more closely and for which we had a biochemical measure. Next slide, please. First, I'd like to review vitamin D metabolism, just for background. Vitamin D is a fat-soluble vitamin that acts as a hormone, and unlike other vitamins, it can be synthesized by the body in the skin from cholesterol after UVB exposure. Whether vitamin D is generated in the skin or is consumed in the diet, it must be hydroxylated in the liver and kidney before it is biologically active. There are few good sources of vitamin D found naturally in food, but fortified foods contribute significantly to dietary intake in the American diet. Vitamin D in the diet and in supplements can be found in two forms, vitamin D2, which is plant-based, and D3, which is animal-based. Both are effective at increasing serum levels of vitamin D, although vitamin D2 may not be as effective at very high doses. Vitamin D is important for bone health, neuromuscular, and immune function, and it modulates genes encoding proteins. The recommended dietary allowances for vitamin D and other bone health minerals were recently evaluated by the Institute of Medicine, and the new guidelines were released in 2010, which was right in the middle of our study. The committee established intake levels based on evidence related to bone health, citing there was no convincing evidence to link vitamin D to other outcomes such as cardiovascular disease, cancer, death, or quality of life. The recommendations were also set assuming that there was no vitamin D synthesis from the sun. There are many factors that affect vitamin D synthesis by the sun, including age, tone of skin, latitude, altitude, and seasonality. And in addition, things like BMI, anticonvulsant use, glucocorticoids also affect vitamin D metabolism. Next slide, please. There have been a few studies published in regards to vitamin D and bone health in children with autism. Hedegar found that the metacarpal cortical bone thickness was lower in 75 boys with ASD aged 4 to 8. Thickness was actually lowest in those who were consuming a casein-free diet. In 2014, Neumeier published results showing that 18 boys with ASD aged 8 to 14 had lower levels of vitamin D and bone mineral density compared to boys without autism. And then there was a cross-sectional study by Furlano who found a lower risk of fracture in a group of 3,219 boys with ASD aged 3 to 8 compared to matched controls. Nonetheless, I think all of us would agree there's reason for concern regarding vitamin D and bone health in children at large, and particularly in children with ASD, because children with ASD can be highly selective eaters, as Susan already mentioned, and exposure to sunlight might be limited due to multiple therapy sessions, which could restrict their outdoor time. Next slide, please. So in our study, we were curious to determine the percentage of children with ASD who met nutritional recommendations for both vitamin D and calcium, and then we looked at those who were deficient in vitamin D based on biochemical analysis. As mentioned earlier, the Institute of Medicine had set new recommendations in 2010, and the recommendations were set for individual intake at 600 international units, except for infants, where the recommendations are 400, and for those greater than 70, and those recommendations are 800. Shortly after the IOM set their recommendations, the Endocrine Society published practice guidelines suggesting more than 600 international units might be necessary to move individuals into acceptable serum levels, and that these levels are depicted on the slide that you're viewing. The Institute of Medicine also set an upper level of intake, which is the highest level of recommended intake, above which the risk of adverse effect increases, and that was established to be 4,000 by the Institute of Medicine. Next slide, please. The Institute of Medicine also established a cutoff for deficiency, which was 20 nanograms per mil, and the Endocrine Society added values indicating that levels between 20 and 29 were considered insufficient and above 30 adequate. There's still an ongoing debate among scientists regarding the appropriate recommended levels of intake for vitamin D and vitamin D status, but we analyzed our data by those who were frankly deficient, those that were less than 20 nanograms per mil, and we also used the Endocrine Society's cut points for insufficiency so that we would have the ability to compare our results to other studies that have been published previously. Next slide, please. So this slide shows the percentage of children who were below recommended levels of intake for vitamin D. The white bar depicts the percentage of non-supplement users who had insufficient intake from dietary intake. The gray or middle bar reflects the percentage of supplement users who had insufficient intake from diet alone, and then the dark bar reflects intake from diet and supplements. So what you can see is up to 90% of children did not achieve recommended intake levels for vitamin D from dietary sources. And although supplementation significantly decreased the percentage of those not meeting requirements, still about 30 to 40% of kids did not meet recommended levels of intake even after they were supplemented. And individual dietary supplementation of D varied by site. 2% of children in Little Rock were given an individual vitamin D supplement, up to 18% in Rochester, where Colorado and Cincinnati, Denver and Cincinnati, 7% of the kids were given a vitamin D supplement, and in Pittsburgh it was 5%. Next slide, please. Although a greater percentage of kids met their recommended levels of intake for calcium, you can see about 60% of kids in the older age group did not meet recommended levels of intake through diet alone. And even after supplementation, even though there was a statistical improvement in intake in the percent that were below suggested levels for sufficiency, still about 40 to 55% were considered insufficient. Next slide, please. We were also interested in the gluten-free, casein-free diet, which is used by families of children with ASD in an attempt often to improve behavioral symptoms. And in our study, about 12% of families use this type of diet. Due to the restrictive nature of this diet, we have concern about vitamin D and calcium adequacy. And we found that those on and off the diet had very similar levels of intake of vitamin D, but that those on, so you can see that in the white and grayish bars. So that's vitamin D intake from dietary sources alone. And then the dark bar, where vitamin D supplementation was added in these individuals, you can see those who were on the gluten-free, casein-free diet actually did a better job at supplementing adequately compared to those who were not on the GFCF diet. So after supplementation, about 18% had insufficient intake for those on the diet compared to 38% on those who were not on the diet, who both took supplements. Okay, next slide, please. We were also interested in learning about the top sources of vitamin D in the diets of children with autism. And as this slide shows, the food sources from which children obtain their vitamin D is very similar to that of kids in the general U.S. population. The main sources are fortified foods, including milk, fortified beverages, including juices, cereals, yogurt, and some kids did eat fish, and that does contribute significantly to dietary intake. Okay, next slide, please. So we had this slide, we had 368 children who consented for our study, and of those 368, 292 completed 3-day food records, and 221 agreed to have lab values obtained. And you could see this slide shows the distribution of subjects by site and race. And so you can see that it's the number of individuals at each of the sites. So Rochester had 49 individuals who were willing to give us lab data, and Colorado 61, Arkansas 42, Pittsburgh 26, and Cincinnati 43. And the race distribution was similar to the overall population at the 360 individuals in our study. Okay, next slide, please. So we looked at serum vitamin D in the 221 subjects and found that the percentage of kids who were deficient based on less than 20 nanograms per mil, and that's in the darker blue bar. The pink bar indicates the percentage of individuals with lab values between 20 and less than 30, which is considered to be insufficient by the Endocrine Society. And the last lighter blue-greenish bar reflects those who would be considered sufficient by the Endocrine Society with values greater than 30. And so what you can see is the percentage of kids who were deficient ranged anywhere from 6% in Rochester to 33% in Little Rock. And it was 14% at Cincinnati, 11% at Pitt, and then 8% at Colorado. Overall, 14% of children with ASD were considered to be deficient in our study and 54% insufficient. And we weren't quite expecting that we would have lower levels of vitamin D deficiency compared to Little Rock, but we did. And the percentage of kids with vitamin D deficiency, if we have a benchmark of NHANES data, about 18% of children in HANES from ages 1 to 11 are considered deficient and 95% insufficient. Okay. And one last comment I want to make on this slide is we were also, one of the things we were interested in finding out is whether vitamin D intake correlated with serum levels. And we're still working on the analysis, but so far what we've seen from the correlation is that when intake is doubled, there's a 50% increase in the odds of having a serum level greater than 30 nanograms per mil. Okay, next slide, please. So as with the vitamin D data, there are with the omega-3 data, there's limitations for the vitamin D data. So we learned some interesting things about vitamin D and serum levels, but some of the limitations are similar to what Susan commented on in the omega-3 data, that we do not have any confirmatory analysis of the vitamin D content of nutritional supplements. Unfortunately, the FDA loosely regulates dietary supplements, and therefore we can't be certain that what was listed on the label was actually what the person got when they ingested the supplement. Second, although we evaluated dietary intake of vitamin D and measured serum vitamin D levels, we did not have any direct measurements of bone mineral density, such as DEXA scans. So it would be helpful to have that data on bone health of the participants in the registry, but we don't have that at this juncture. And third, we did ask about sun exposure and use of sunscreen, but we did not have direct measurements of either of those in terms of sun exposure. And lastly, we did collect information about race, but we did not record information about skin color or skin tone. And all of these factors, as you know, affect vitamin D status. The next slide, please. So many children with ASD, so in conclusion, what I'd like the take-home message is to be, as Susan pointed out for omega-3, is many children with ASD do not consume adequate vitamin D even after supplementation, and a significant number do not meet calcium requirements with or without supplements. Children with ASD obtain vitamin D from similar sources, food sources, compared with typically developing children in America, and most of the children at most of the sites were not vitamin D deficient, but several were vitamin D insufficient. And vitamin D intake and status should be discussed at all health supervision visits, and dietitians can be very helpful in identifying foods that are high in vitamin D and appropriate supplements that are acceptable to children with ASD. So that concludes the talk on vitamin D, but if I can have the next slide, I'd like to give thanks. So this work really has been a labor of love. Doing food research is always interesting, and it took a whole host of people at multiple sites that you can see listed on the slide, all our coordinators at the 5 sites. And we would like also to give thanks to the MGH Coordinating Center, and especially the statistical support that we get from the team there. Terrific bunch of people that have helped us tremendously. Thanks to MS for their support as well. And of course to HRSA, through Autism Speaks and ATN, because without their support, this work would not be possible. Lastly, the CPSI here at the University of Rochester has given us lots of support in terms of analyzing the food records, and I'd like to give a special shout out to Robin Peck for all her hard work in analyzing the diet records for us. And the last slide, of course, and the Cornell interns are instrumental as well. They're on there. And the last slide, of course, most importantly, the families and children with autism who participated in this study. Thank you.
Great. Thanks very much, Pat and Susan. Wonderful presentation. At this point, we're going to open things up for people who might have some questions. Jesse, if anyone's raising their hand, feel free to unmute them, or perhaps unmute the entire audience so that we can have some discussion going here.
I'll actually go right ahead and unmute everyone so that we can just have a good discussion. Okay.
Hi, did people not hear me? Hi, this is Susan Levy. Can people hear me?
Yep, we can hear you now.
Okay, good, thanks. This was a wonderful, wonderful study and presentation. And I have some practical-based questions, because a lot of our families use supplements and special diets all on their own. In terms of omega-3, do you have any suggestions about how we should be guiding families if they wish to supplement with omega-3 fatty acids, and what's the best sources that they should be trying to use? Hello?
I can hear you, Susan, but I can't hear anybody else.
No, I wondered if I dropped off the whole of the earth.
I don't know. I'm on.
Did we lose all the speakers?
It appears so.
I'm sorry. I shouldn't laugh.
Maybe I'll write in a question. Here we go. I'm going to type it in. I think the whole thing fell apart.
Oh my God. This is Lynn, right?
This is Lynn. They did a great presentation.
They did. This is unreal.
Oh, am I back on? Okay. So the question was, what supplement should you use if a family elects to use an omega-3 supplement? And the answer is you would want to use a supplement that contains DHA and EPA, but is not a fish liver oil. So cod liver oil is not something that we would recommend because it is usually higher in vitamins A and D, and it's quite easy to reach the upper limit, the limit at which you get side effects in vitamin A, which can also be toxic. So we would recommend using an omega-3 supplement that is EPA, DHA, and that is not ALA, not the plant-based, because the plant-based you have to take a whole lot of, and it's really not well understood about how much of that becomes physiologically active. And Pat, would you like to comment about just picking supplements in general?
Sure. It's tough. As I mentioned, the FDA loosely regulates the dietary supplement products. And so some of the things we look for in terms of using good manufacturing processes, that is a legitimate term by the FDA, so companies that use GMPs is something that is very helpful to ensure that perhaps the vigilance is there in terms of having what is listed on the label actually in the bottle. There are a couple other symbols you can look for, USP, which also indicates that, again, that they are more vigilant about ensuring that what is listed on the label is in the bottle. So those are two. Consumer Labs is another one, CL on the label. So just a few things you can look for in terms of ensuring that you're more likely to get what's listed on the product label. Anything else, Bree? Are there any other questions?
I thought Susan Hyman was, or I thought Susan Levy had a question there. I got disconnected.
About omega-3 fatty acid supplementation.
Yeah, yes, and Susan Hyman did answer that. We were all, Susan was muted, Susan Hyman was muted for quite a bit of time, and she came back on and she did answer that question.
I was also, and I wasn't even hearing some stuff there, so great. So I did want to ask about the vitamin D levels and the comparisons across the sites, Pat. Could you comment again about why Arkansas looked so different from the other sites?
I know, we were really quite surprised to see that, but I can say, and again, we are in the middle of analysis, Dan, as you know, but Rochester had the lowest level of deficiency prevalence in terms of deficiency, which was shocking to us, but we also had the highest use of supplements. So 18% of our kids use supplements compared to 2% in Arkansas. So I have to applaud our team here at the Center for Developmental Disabilities at Strong, and I think that they do a great job at assessing and also recommending supplements. And Susan would like to say something as well.
When we picked the sites, when we, for the original study, we very much wanted to have Colorado and Arkansas because unlike Pittsburgh and Rochester, they actually have sun. So we wanted to have a variety of locations because latitude as well as altitude can impact your sun exposure, which is not insignificant. And we were actually very surprised at that data.
Another common concern that a lot of clinicians have when they hear that the families are giving supplements is some concern that perhaps the child doesn't need it in the first place, and are they going to get too much? But we didn't really see many of your subjects with excessive amounts of intake, did we?
Not with these two supplements. I'm going to let Pat answer that.
Yes, so for vitamin D, we did look at the percentage of individuals who took above the upper limit, and again, that upper limit is set by the IOM as the highest recommended level of intake for which side effects have not been found. And we had about 2% of individuals in the young age group and about a percentage of 1% in the upper age groups who did take levels above the upper limit. So so it's not, we try to advise individuals. That's why I put up the 600 international units to show you what is recommended through the Institute of Medicine. And then the Endocrine Society suggests that if that doesn't move levels, to go up to about 1,000. But most people are not supplementing enough. We thought we would find great for vitamin D. And we thought that we would find a greater percent of individuals above the upper limit, and we did not find that.
Very good.
Okay, and Susan is just reminding me to say that we just submitted the paper about supplement use, and a lot of this data is in there. So is there anything else you wanted to comment? Yes, okay, yes, and then Susan just wanted to comment that kids who use supplements, especially multivitamins, several of them did go above the upper limit for nutrients such as zinc and vitamin A and copper, especially in the younger age group. So we do have concerns about those nutrients in terms of excessive levels of intake.
Oh, very good. Wonderful. Any other questions from our audience today? Well, if not, again, I want to thank Dr. Hyman and Dr. Stewart for their presentations, for providing all of this data regarding the AIRP nutrition study, and we're looking forward to seeing more of this coming out in print in the near future. If there are no other questions or comments, I think we're going to adjourn a little bit early today. I hope everybody has a wonderful week. Bye now.
Thank you. Thanks.